focus on crisis respite services. And the presenters, myself, Boris Ulgorin, I'm with MCTAC NYU. We also have Doug Ruderman, who's joining us from the New York State Office of Mental Health, Brenda Harris-Collins from New York State Office of OASIS, and Lauren Distel from Community Access, who will be presenting on some of the case examples with us. So I first want to thank our presenters and making themselves available and joining this presentation. So just a quick couple of housekeeping rules, just quickly to go through. One is this presentation is already posted on the MCTAC.org website. Also, if you have any questions, we invite folks to chat them through the chat box that is located on your lower right corner. We'll be collecting those questions throughout the presentation, and then at the end, we'll allow time to answer those questions, and hopefully we'll be able to go through all of them. Also, this presentation is being recorded, and we expect that either towards the end of this week or early next week, the recorded version of this presentation will be on the website as well. And for those individuals who might be joining MCTAC for the first time, just a quick overview of what is MCTAC. So we're a training and consultation resource center that offers all mental health and substance use disorder providers in New York State the training and consultation services. And of course, we provide the intensive support on quality improvement strategies, which includes business, organizational, and clinical practices. And the overall goal is to really get ready and assist providers in transitioning to managed care. Okay, so before we jump into this particular presentation, just an overview of additional HCBS training topics that are either already being developed, presented on, or will be coming soon. There is a training that's already available to the health home care coordinators. That's on the New York State Community Health or Mental Health Assessment. Previously also was referred to INTERI. There is development going on the eligibility and workflow. Also additional trainings that will be coming soon that will be distinguishing the state funds and other funded program versus HCBS. And of course, there'll be training coming hopefully in fall, late summer on the plan of care for HCBS services. The goal of this presentation is to really focus on the vision of HCBS services, but in particular today on the crisis respite, their definitions, the components, the business billing rules, and the examples. With the understanding that this is more at a probably 20 to 30,000 feet look, and in fall or early winter, there'll be more in-depth presentation on these services that would get more into the specifics and maybe even talk about how they would get implemented. This is, again, just to give an overview of what this service is and to get folks ready in the transitioning to the service. So just to highlight out of the scope of all the HCBS services, where this particular service rides. It's referred to, at least in the manual at the moment, as under the crisis intervention cluster, and there are two services that we'll review today, which is short-term crisis respite and the intensive crisis intervention. To date, and these numbers might have actually changed since we posted this, there were 26 providers in New York City that were designated for short-term crisis respite and 16 for intensive crisis respite service. Again, these are New York City designations. I think the rest of the state just started the process. And between the two of them, the 26 and 16, there are a number of providers that are the same who have been designated for both services. So if you're doing the math, the total providers is not necessarily 42. it's probably less as a whole cohort of providers. And without any further ado, I want to then pass this along to Doug and Brenda, who now would take us through the crisis respite and all of the services through this. So Morgan, if you can just pass this to Doug and Brenda, and also unmute them, that would be great. Thank you.
Good afternoon. This is Doug Ruderman. Glad to be here again to talk to you about a couple of important HCBS services. And Brenda is also on the line, and we'll be both, giving different perspectives of this service, probably very similar perspectives, but I'm sure there are some nuances regarding OASAS providers and people with substance use versus those people with mental illness, although we know many of our folks unfortunately have both disabilities. So right into the crisis respite services. There are other two services that we'll discuss today, the short-term crisis respite and the intensive crisis respite. And they're important services because they are going to be services that are going to hopefully prevent people from ending up in emergency rooms and ending up on inpatient units, which are neither good experiences, both traumatic experiences, and also could more readily lead to people losing some of the things that they've managed to put together in their lives, and their living situations, their relationships with friends and family, jobs. Any number of things can get disrupted for the long term when people end up in emergency rooms and then in a hospital. So we're trying to avoid that from happening. The good thing about the service is that because it is something that can't really be planned, it's not required that the community health assessment indicate that this service is needed. So it's not the type of service that you are putting in a service plan ahead of time, understanding that these are not planned services. These are services that occur when people are in particular situations that require them, that we'll describe later. But all of the people need to, or the people do need to be enrolled in HARP, in the HARP product, because it is an HCBS service. It is available to those people that are enrolled in HARP. Okay, now trying to figure out how to move the slide forward. My arrow buttons don't seem to be working, so I don't know if there's somebody who can explain to me real quick how to move it forward.
We can try to move it for you, Doug, for now, but it should be on top.
You got it.
Yeah, but we'll have Morgan move them along.
All right. I'm sorry. I'm technologically impaired. Okay, short-term crisis respite. Short-term, as the bullets say, short-term care and intervention strategies for individuals who are experiencing challenges in daily life that create a risk for an escalation of symptoms. So here we are. We're with a program that is there for individuals who are experiencing difficulty in the community at the moment, and we're concerned, and the person is concerned that they need a little bit more support, and perhaps to be in a more neutral and supportive setting in order to be able to continue to function in the community and avoid a hospitalization. Imminent risk for an escalation of symptoms, so there's got to be some assessment that is made that basically says that if not for this service, this person is probably, unfortunately, going to be worse off regarding their symptoms and might be putting themselves, and as I said before, some of their things that they've gained in their life, loss of adult role functioning, it says here, at risk. A challenging emotional crisis occurs where the individual is unable to manage. So, you know, these are usually, there's some stressor, there's some situation that occurs that a person is not prepared to cope with well, and so when those circumstances come up, and that's why they're unplanned, because you don't know when these things are going to happen, this is a service that can be beneficial to a person. You know, and the person might end up in the emergency room first, and in order to try avoiding an inpatient hospitalization, the emergency room could make a referral to the short-term crisis. There are referrals from the community, so family members might work with somebody to, you know, to recognize that a short-term crisis respite a good program and make a phone call. The individual themselves might refer themselves. The treatment team, which I'm going to include all health, behavioral health, care management services that the person works with, any and all of those members could make a referral. Again, with a conversation with the individual, because these are client-focused services. This is a voluntary service, so there's no point in making a referral to a service unless if you've already discussed with the person the benefits of the service and they've said that they'd be interested in either participating or learning more about the service. It also can be part of a step-down plan from an inpatient setting. So it's not an alternative living situation, permanent living situation, but sometimes the transition from the inpatient unit into, or inpatient setting into their independent living situation or other community living situation, perhaps a respite, a brief respite with some support to help with that transition might prove helpful and make that transition successful. And crisis respite is provided in site-based residential settings. Okay, so there are a lot of reasons why you would provide this service. If you can move forward. Oh, thank you. There are a number of components of this service. Peer support, either on-site or as wraparound. I think that's one of the strong services that can help support people as they are going through difficult times, is to work with a peer who can use their lived experience to help somebody to not only understand or what they're going through, but to also let them know that other people have gone through these difficult periods as well. Health and wellness coaching, I think that we talk about this in a couple of different places, but you know, sometimes people need a little help in figuring out things that could be helpful to them. So I'll tie that into the wellness activities. So people don't realize what a good walk might help somebody do, breathing exercises, other things that are not necessarily treatment or medication that can help them to feel better and ameliorate a crisis situation. Of course, recovery and crisis plan development, an example of one of those is RAP. So it's always better to have a plan that can be implemented, that an individual agrees to at a time when they're starting to do better, to help identify when they're starting not to do better, and what services they would prefer to be offered at what points in time to help them to, you know, avoid a crisis. So recovery planning is very, very important, and that's another service that can be provided within this service. It's a really advisable thing to do. Family support, of course, if a person has the support of their family, the family can not only come and be supportive, but also the program can work with the family to help them to understand what might be going on right now and how they could best be of support to the person during this crisis situation. Conflict resolution, it could be a roommate issue, it could be some other issue that might have spurred this crisis, and there might be the need for some people to work with the person around how to resolve that conflict that might have promoted the crisis situation. Okay. The next slide, please. Yes, thank you. Working with existing treatment providers is going to be very important, and I'll tie that into the third bullet, coordinating with primary care, health home, or other behavioral health providers. Most if not all of the people in HARPs are going to have a health home and a health home care manager, so it's going to be very, very important to include that person moving forward and how the individual is doing, what other new supports they might need when they leave the short-term crisis respite, and perhaps also to help to coordinate with those other primary care and behavioral health providers. There might have been identified that there are other services that could be beneficial to the person going forward. Relaxation techniques, I'll tie that into a lot of the wellness coaching and the wellness activities that we talked about earlier. Ongoing communication, and that's an important thing, is that you got to find out from the person not only to communicate with them, but who else do they want you to communicate with, family, friends, and others. Crisis respite staff, together with the individual and his or her established behavioral health providers, will make a determination as to the continuation of necessary care and make recommendation modifications. So what we're saying here in a lot of these bullets is that, this is a team process. The team being the individual is at the center of the team, and then you as the crisis respite staff, along with the health home and the health home care manager, the HARP, which needs to approve plans of care and services, and other service providers, other significant others that are identified by the individual. Everybody has to work together to get through this short-term crisis, get the person back to where they were. Okay, next slide. Business and billing rules. Okay, so this is a face-to-face service. Obviously, the person will be at the crisis residence. They'll be receiving the services there. Site-based residential settings will offer a supportive home-like environment with a maximum preferred capacity of 8 to 10 guests, few in rural areas, preferably in single rooms. So what we're trying to say here is that you just can't open up an apartment and say that this is where a person's going to stay while they're in this service. The service needs to be a setting that has been approved for the sake of economy of scale, and because it makes sense that there'll be a building that will have more than one, as we say, a preferred capacity of 8 to 10. We understand that in some rural counties they might be smaller, but in New York City we would expect the programs to be able to serve 8 to 10 guests, and we recommend single rooms. For safety's sake, of course, the buildings have to be code compliant. The buildings, when a resident is present, is staffed, and it's open 24 hours a day, 7 days a week. So we're saying if by chance there were nobody who was participating in the service, you don't necessarily have to have a staff there and present. if there's no resident using the service at that time. Residents should be allowed to leave and return as needed. These are not locked buildings, locked units, locked wards. It's going to be very important that people are able to function as independently as they can and do as many of their normal daily activities as they usually do. And the prime example here is that if somebody has a job and they're able to, they should be able to go to their job and then return from their job. And then to the greatest extent possible, guests will be encouraged to make contact with significant others, including family members, friends, and spouses. It's very, very important. This is not a clearly only professional setting. This is a setting where people should be supported by their natural supports and their professional supports. So next slide, please. We'll continue. Admission eligibility criteria must be experiencing crisis, which is the whole point of the service, is to help people that are in crisis, willing to voluntarily stay at the crisis respite. And as I said before, this is a voluntary program. If the person doesn't want to come to the crisis respite program, then they shouldn't be part of the service. So they need to say they want to go to the program. Willing to be assessed by a treating professional. So at some point, they have to say, yes, I understand part of what I'm doing is talking to somebody and explaining to them how I got into this crisis as best as I understand it, so that they can help me to work out what's the best way to get out of the crisis. Willing to authorize release of medical records by relevant treating providers. Information is very, very important, there's no pre-assessment required for this service, so there's going to need to be some kind of assessment at the time. So these two bullets are kind of linked together. You need to get medical records from people in order to understand, what's their medication regime if they're on a medication, when do they need to be at their treatment service. We want people to continue to go to their outpatient behavioral health and medical health appointments as needed, and that they're experiencing challenges in daily life that creates an imminent risk for escalation, and we kind of went through that in the beginning. Some of the exclusions here are a diagnosis of dementia, organic brain disorder, or TBI. Those with acute medical conditions requiring a higher level of care. So obviously if somebody needs some kind of medical intervention that can't be provided in a short-term crisis respite, it's not the appropriate setting for them. An imminent risk of to self or others that requires a higher level of care. And we'll talk a little bit more about that when we go into the intensive crisis respite service. Displays symptoms indicative of active engagement in substance use manifested in a physical dependence or result in aggressive or destructive behavior. And I don't know if Brenda wants to, expand upon that for a moment or not.
Yes. So this particular exclusion is something that is still being discussed. We're looking at, a person coming into a crisis respite and they are currently using and making sure that there is some withdrawal management that may be needed, but the person also would not be able to use any substance or engage in active substance use while in that particular resident crisis respite. So this is something that is really, that we're still discussing, that we will be ready, define a little bit more clearer. But at this point, if a person is actively engaged in substance use, they will not be able to attend the crisis respite.
Thank you, Brenda. And I think we're going to have lots more detail for you we continue to build more specificity into these services, and as Boris said earlier, sometime in the fall or early winter we'll be providing more information and getting down into the weeds about all of these services. Is not willing or able to respect the follow the guest agreement. So there's going to be an agreement that people are going to be asked to sign that basically sets down, the rules. And, whenever you're living in somebody's house, there are rules. And so the individual needs to be able to say that they'll agree to the rules and follow the rules. You have to sign registration documentation. It's a voluntary program. So if the person's saying, yes, I want to be in this program, they should sign whatever information is required in order to admit the person into the program, and is not willing to participate in the wellness process during his or her stay. So if you're saying that you don't want to do anything to help ameliorate your crisis, then the crisis respite service is not the appropriate service for you, because it's not just a housing, a place to just to be warehoused for a few days. It's a place where you're actively going to be working on your wellness. So those are the exclusionary criteria. Next slide, please. Let's see, no longer than, the limitation is no longer than 1 week per episode, not to exceed 21 days in a year. Okay, so, it's not a math thing. It's not like you can have 3 1-week episodes per year only. You can't go more than 21 days. So if you have an episode of care that's 3 days, you still have 18 days available if you were to need them, but no one episode can be greater than a week. Individual stays of greater than 72 hours require prior authorization. And I'll have to expand upon that at a different date, because although there's no assessment process, I believe what this is indicating is that the managed care company should be informed, the HARP should be informed that the person is participating in the service, and if they're there more than 72 hours, there should be a conversation with the HARP to describe why the more than 72 hours are required. And then if somebody needs more than a week on an individual basis, that could be approved by the managed care company or the HARP based on medical necessity. While the individual receives ACBS crisis services, they can't not simultaneously receive peer services. And that's because we said that peer support is part of this program. So you wouldn't receive peer support as part of this program, and also peer support that would be funded as a separate service. That would be basically paying for the same service twice. Certification provider qualifications, you can be a peer or non-licensed staff, so you don't necessarily need to be licensed staff in this particular program. There should be a program director who has 3 to 5 years of management experience working in social services or related setting, and they'll supervise the staff of the crisis respite program and coordinate the daily activities. Peer respite staff in mental health programs will have experience as a recipient of mental health services and a willingness to share personal, practical experience, knowledge, and firsthand insight to benefit program enrollees. If you're going to be working there as a peer, those are the features of being a peer that tend to help make a peer-to-peer relationship work very well. Peer respite staff will possess the competency to meet requirements outlined in the job description, will complete any relevant trainings within 90 days of employment. All peer staff must be OMH certified peer specialist or OASIS certified peer advocate. And when I talked about the lived experience, and I'm going to let Brenda expand upon this again, but from the Office of Mental Health perspective, you know, peer specialists are individuals who have lived experience. It's a little bit different, I believe, on the OASIS side. Is that correct, Brenda?
Yes. So on the OASIS side, we have 2 certification groups, and one of them you have to have lived experience, and the other lived experience is looked at as a positive, but you do not have to have lived experience. So because of that, makes us very different from OMH, in that we do have some peers that do not have lived experience. They may be a family member in recovery. They may have had years of it. They still have to have many years of experience in the field and some connection to the field. They cannot just come and be a certified peer advocate without some connection to peers. So that makes us kind of different in how we look at the certified peer advocate.
Thank you, Brenda. The last bullet on this page, the staffing ratios, case limits. So, you know, based on the number of guests, so 1 staff person on site for every 4 guests. So once you have that 5th guest, then you need to have a 2nd staff person there. And those are during daytime hours, 7 a.m., that we define as 7 a.m. to 8 p.m. And then the other hours of the day, 8 p.m., between 8 p.m. and 7 a.m., there shall be a minimum of 2 staff on site. And the director or designee shall be available at all times by cell phone. So staff should always have cell phone access to the director or one of their designees. Okay, next slide, please.
Okay. All right, Doug, so thank you. I think that covers the overview of the short-term crisis respite, so thank you, Doug and Brenda. Anything else, Doug or Brenda, you wanted to mention before we jump into the example of this service?
No, I think we're good.
Okay, thank you. So I'll turn this over to Lauren now to go through the OMH example, and which would then be followed by Brenda going over the OASIS example. So Lauren, take it away.
Okay. Hello, everybody. I'm going to talk about, in this case study, a 47-year-old Hispanic man diagnosed with schizophrenia, a long history of refusing psychiatric care and medications, a long history of hospitalization, living with his family, but in conflict with them and getting worse, and also in conflict with other people in his community, and really walking around in a really, with a real short fuse, I guess I would say. A positive is that he had a good relationship with his care coordinator who knew about the respite and who brought him to us. And his first words when he walked in the door actually were, he said, I need help, I need refuge, I'm under siege. So he walked in the door wanting this help and this recovery. So coming into the respite, he finds a really warm environment. It's comfortable. He gets his own bedroom. He's not challenged about his belief systems, which are, quite different than those of his family and his community. He's able to engage in all kinds of conversations with staff. Some of the peer staff having had very similar lived experiences than his own. He's able to engage in all kinds of activities, relaxation exercises, go for walks in the company of the other peer staff. He was even able to visit a Buddhist temple, something that he'd wanted to do, and staff accompanied him to do, not something that staff would have to do at all, but something that he wanted an opportunity to do and was able to do. His family was able to visit him and came several times during his stay, as well as his care coordinator. And by the end of his stay, first of all, he was a lot calmer, and he'd really developed in his interactions with his staff and some conversations like RAP planning and develop different strategies to learn to bring down his emotions and to find better ways to talk things out and talk out conflict. He was able to return home a little better off. And for someone who had refused to see doctors, he actually had shared with his care coordinator that at the end of his stay that he would think about maybe talking to a doctor and think about taking medication at the time he left, which just is an example of just really the kind of change that can happen in a very short period of time.
Great. Thank you, Lauren, for that presentation. Morgan, if we can move that to the next slide. And we'll pass it over to Brenda, who's now going to do the OASIS example for the short-term crisis respite.
Okay, so for OASIS and the case example that's being used currently for substance use disorder, there are not crisis respites in existence. However, this short-term crisis respite is an example of what it could look like if this was available. And, you know, I spoke with someone who had someone who really could have used the short-term crisis respite and was really in need of a short-term crisis respite. And we're going to talk a little bit later about the intensive, and I think that for those who are substance use only, the intensive is probably not the service for them, but the short-term crisis respite could be for someone who's substance use only to prevent costly detox, etc. But in this case, we have a 22-year-old African-American female who lives at home with her 3-year-old son, and until recently also the father of her baby. And they were attempting to make a goal of life, but recently the father died. He wound up relapsing. He also was a substance user, and he wound up relapsing on heroin and had an overdose and died. This 22-year-old had completed high school, was enrolled in school for medical billing, and had work experience as a home health aide and care attendant, and was employed at the time. This young lady was as a child was growing up, didn't experience mental health issues, she thought, but there was something that was going on. She didn't really understand it, and she began to utilize and smoke marijuana. She fell in love with the way that it made her feel, and she noticed that when she smoked marijuana, the noise in her head tended to quiet down, and her breathing was more relaxed, and the world didn't seem so scary. She was asked if did she ever tell anybody about the noise in her head, and she stated no, because she never really got in her way, but it was beginning to become noticeable in her daily routines. She reported that she began to realize that the more she smoked, the more relaxed she felt. There was no anxiety. So she was self-medicating in some ways. At first, marijuana was a way to take the edge off, but she began to increase, and her usage increased greatly. And she just needed it to just even feel normal and adequate. She was on her way one day, however, to go shopping with her baby, and she was beginning to feel as if the walls were closing in on her, and she didn't understand what was happening. She had normal use of marijuana, she thought, but something was wrong, and she really started having these panic attacks. And over the next 3 months, the panic attacks happened more and more, and she actually increased her use from marijuana to K2. And then at some point, there was a complete meltdown, and the police had to intervene. The results of this police involvement left the 22-year-old female with a referral for drug treatment but not mental health. After admission at the program, she was assessed that she would benefit from a mental health evaluation, and she was diagnosed with cannabis use disorder, bipolar, and anxiety disorder. She began medication, but something with the loss, a situation occurred that really triggered her, and even though she had been improving with the loss of the father of her son, and she just really began to have a breakdown, and even though she had 30 days of abstinence, she just was not able to continue moving forward in the way she had previously. And at this point, an ambulance was called because she really was not able to control the noises, she had really a lot of craving and urges to go use substances. She began to explain that there was so much on her plate, citing school, the work, the baby, and the recent father death, and just was overwhelming, and she was consistently overwhelmed. All of this was taking a toll, and sometimes she just wanted to give it up. She had been found not to be a threat to herself or anyone else, but was still very fragile. And she was really vulnerable to relapse, and she did not have a recovery plan in place. So her going into crisis respite would have been very helpful to her. She didn't warrant a full hospitalization, but some intervention was needed. Options would be explored by the treatment team. The option of short-term crisis respite really was an excellent option because she had a 3-year-old son. Her mother was willing to take care of her son temporarily, but this would allow her to see her son without the separation anxiety that her son may feel or that she may feel from being away from her son. Her mother was a great support too, so her mother would be able to come to the crisis respite and really begin to learn even more how to support her daughter. She was able to maintain school and work, but now take the time with a peer to also find ways to cope with her loss, stresses, emotions, and develop a recovery plan and relapse plan, preventing hospitalization, possible rehab admission, or stabilization. So this would be a really good option for this 22-year-old to really put some things in place, still have her be able to see her family and deal with her family, as well as preventing some costly hospitalization or rehab admission or stabilization. Thank you.
Great. Thank you, Brenda, for this example. Now we're going to move over to intensive crisis respite, and I'll pass it back to Doug and Brenda. Thank you.
Yes, and those were two very fine examples of the use of a short-term crisis respite. And now we're going to talk a little bit about the intensive crisis respite, which is a more clinical model and a model that is designed to serve people that need a little closer attention in order to keep them or for them to remain safe in the community and to hopefully get back to where they were before they entered the program. So it's a short-term residential care and clinical intervention strategy to individuals who are facing a behavioral health crisis. And you can see where all of these things are like a notch above the intensity of what we were talking about in the previous service. So individuals who are suicidal, who express homicidal ideation, experience acute escalation of mental health symptoms, persons must be able to agree on a suicide prevention plan. So that's very important. If, people are able to accept some risk, but they need to also be able to say that, that I'll follow a plan while I'm in this service that, will help me to prevent me from completing or committing suicide. Individuals are an imminent risk for loss of functional abilities and may raise safety concerns for themselves and others without this level of care. And the immediate goal is to provide supports to help the individual stabilize and return to the previous level of functioning, or as a step down from inpatient hospitalization. So you get the picture here. You have people that are in a much more unstable state. They're at greater risk of losing community tenure. It's not even so much of worrying about life roles here. It's worrying about safety here. It's worrying about how can we quickly get somebody back to a place where they're stable enough to start to work on their recovery plan again. So next slide. Okay, next slide, please.
Doug, I think those are the components for the next slide, yeah?
Oh, I'm sorry. It looks like the same slide as before. I apologize. Short-term residential care and clinical intervention strategies for individuals who are facing a behavioral health crisis, including and these are very similar to the previous slide. That's probably why I didn't realize it. There we go. Components, comprehensive assessments including screening for physical health conditions. So, you know, here we're looking at the person in an integrated way. We're not just looking at their behavioral health problems, but also their medical health problems, because sometimes, you know, behavioral health symptoms can come because of a physical health condition. And I'm just going to do a quick off-the-cuff example of something from when I, at some point in my career, I ran a mobile crisis team, and we had somebody who had continuously been calling the police that they felt that they were being raped in the middle of the night, and the family was very concerned because the family was home. They knew nobody was entering the building, entering the home, entering this woman's bedroom, and what it ended up turning out to be, after we were able to get her to see a medical doctor, was that she had a very serious UTI infection, and she was misinterpreting that because of a thought disorder into that the pain was that because she was being raped at night. And so you really have to make sure that there are physical health conditions that are being diagnosed and being treated as well. So comprehensive risk assessment, medication management. Again, there might need to be different medications, titration of medications, you know, and that's why this needs to be a medically supervised and clinically and clinical program. Individual and group counseling, which are services that are provided by licensed clinicians, training in de-escalation strategies, again, relaxation techniques, monitoring of high-risk behavior, and psychiatric evaluation for competency. So as you can see here again, everything is a step more clinical and a step more intensive regarding concerns for safety. Okay. Next slide, thank you. The program should include components that link to appropriate resources and make referrals. And again, you know, this is a team approach. The intensive crisis respite program should be communicating with the health home, with the care manager, with other providers to make sure that there are appropriate referrals being made when needed. Peer support. Recovery and crisis plan, and again, we give an example of a RAP plan, the wellness activities, family support, engagement, natural supports, conflict resolution. And here's one that we didn't see earlier, hotline. You know, we have ongoing communication and clinical staff here together with the individual, make recommendations for modifications to the recipient's plan of care. So many of these services are similar, these components, so that this is, again, can do what the short-term crisis respite does, but in addition, now we have the clinical component, and we have the medical supervision, okay? Okay, modality, face-to-face again. The setting, participants are encouraged to receive respite in the most integrated and cost-effective settings appropriate to meet their respite needs, preferably in a residential community-based setting. Admission eligibility criteria, individuals may be a danger to self or others and are experiencing acute escalation of mental health symptoms and or imminent risk for loss of functional abilities and raise safety concerns. So here we are again, all of this stuff you see makes this a bit more intensive and a little bit more concern for safety than the short-term crisis respite level. Experience symptoms beyond what can be managed in a short-term crisis respite program. And individuals does not require inpatient admission or can be used as an alternative to inpatient admission if clinically indicated, and the person can contract for safety. And that's, without a service like this, people might show up at an emergency room and the decision might be made that we need to admit the person to the hospital because we have to, with the person, make sure that they're safe. This gives an alternative to going into an inpatient setting, and in a community setting, this is considered to be less traumatic to the individual than an inpatient admission might be. So limitations and exclusions, here we again have the 7-day maximum, again 21 days per year. Individuals requiring intensive crisis respite, excuse me, for longer periods may be evaluated in a greater length of stay based on medical necessity. So you can request more than 7 days. If necessary, and have an acute medical condition requiring a higher level of care. So these are the exclusions. So 7-day maximum, again, I know I just went through them, but I'm going to, if somebody needs, is thought to need more than 7 days, this is probably not the service. You might be looking at an inpatient admission. If a person needs longer periods of time, it may be allowed. And, you don't go to this program if you need a higher level of care than this. And the next higher level of care to this is inpatient admission, I believe. Okay, next slide. Boy, I think that the print gets smaller and smaller on these slides, even for me to take a look at them. So certification provider qualifications. The agency must possess a current license to provide crisis and or treatment services. I'm not sure if license is the correct word. I'll have to double check that. I think that they must be designated to provide crisis and treatment services. No, excuse me, I'm misinterpreting this. In other words, they must be licensed to provide one of these other services currently in order to obtain the designation to become a intensive crisis respite provider. This service will be provided by multidisciplinary team of licensed, paraprofessional, and certified peer staff. So you need to have an adequate number of staff and appropriate staff composition to carry out the goals of the program. So this is a little bit different. There isn't that specificity that was provided in the last service about needing to have, one staff on during the daily hours and 2 staff on during the evening hours and nighttime hours. Here, of course, now we have medical coverage. So backup coverage may be a physician. So you need to have a psychiatrist, as primary medical coverage for the program. Backup coverage may be a physician, because we know that who will consult with a psychiatrist, that somebody is probably not going to be available 24 hours a day, 7 days a week, so we know that there'll need to be some backup. The psychiatrist or physician shall be on call 24 hours a day. So it may not be the primary medical coverage person, but a medical person needs to be on call 24 hours a day. And they also need to come and do daily rounds. Somebody needs to come to the building and see the people who are in this service at least once daily. Counties of less than 50,000 population may utilize, that doesn't count for New York City, but may utilize a licensed physician for on-call activities and daily rounds as long as the physician has postgraduate training and experience in diagnosis and treatment of SMI and SUD, serious mental illness and substance use disorder. At least one registered nurse shall be on duty 24 hours a day, 7 days a week, when there is a consumer in care. So that is not coverage now, that's not on call, that's on duty. So there'll be a registered nurse there at all times when there is a resident in care, a consumer in care at the residence. The models we're looking at are really, there are two different size models, a 1 to 10 size model, 11 to 20 size model. The larger model needs a second RN, okay? So when you go over 11 people, when you go over 10 people, you need to have a second RN on duty at all times. And then mental health treatment staff, I think that these are misaligned. So you need to have, misaligned on the chart, I should say. So the one mental health treatment staff should be when there's 1 to 10 people. So in addition to the RN, another mental health treatment staff, and this says an additional 2 if you go over 10, between 11 and 20. So, I will just have to clean that slide up a little bit. All right, next slide.
Okay.
Yeah.
Great.
Okay, I'm back.
Yep.
I just want to say, I want to preface with this example that we saw this person in the short-term respite. There's not an intensive crisis respite yet, but I thought it would be a good example for this model. We saw a young woman diagnosed with a depressive disorder and avoidant personality traits. She has a history of several hospitalizations, and I'm going to say suicidal gestures, but I think they could also be qualified as attempts, depending how you look at it, including an overdose at one time during a hospitalization. She, I guess you could say, lived a life kind of on the outside, sort of a sense of estrangement I get with her. She had a difficult birth. She was left with some lasting medical conditions, very self-conscious about her appearance, and reported in her being bulimic in her teenage years. So she's new to an apartment treatment program and was experiencing conflict with her roommate, and went out on the fire escape. And of course, this alarmed everyone present, and her housing provider and ACT team and family were, they got her to an ER where she was observed for 24 hours and cleared to go, and was directed to the respite. And she affirmed that, in fact, she was on the fire escape because, in her words, she wanted to die, and she explained that this is something she feels quite a lot and that she's felt throughout her life. And so rather than just go into safety mode and conversation around contracting with her for safety, it was really an opportunity to give her, to let her tell her story, to talk about what that was like and what she meant by that, and to ask her, what is she at the respite for? What does she want to work on? And her words were that she wanted to learn to be more assertive. So again, we have someone who's coming to the respite who knows exactly what they need to work on. And so really it was clear that we agreed that she was going to work on finding a way to find words to express what she was feeling and not taking drastic and dangerous action to express what she was feeling. And so a really important part of that conversation as well, and the next question is, what can peer staff, what can the staff here do to support you? What can we work on with you? What would you like your life to look like? What can we do right now to help you get there? So that's part of the conversation. And then very important is, how are we going to communicate while you're here? How are you going to let us know if you're having a difficult time, a difficult experience, if you're feeling suicidal? What are you going to do to let us know? What do we need to know about you to come to you to talk about what's going on with you? And really making sure at the time of admission that we're able to establish a real clear connection and method of communication. So she came into the respite. She was, again, I think immediately is able to step out of a sort of defensive posture of explaining herself. And I say again, not unlike the earlier case that we talked about, very different, but again, not needing to explain who they are. And that right there is really a big load off their shoulders. She settles in. She's able to have all kinds of conversations with staff, some who have had very similar experiences, and she's also able to talk about her interests. She participated in journaling groups and in role play exercises, and these really give her an opportunity to practice to find her voice and to practice her autonomy in a playful setting, and really get comfortable with learning how to assert herself. She's able to be visited by her mother and her ACT team, and she's able to take those skills with her, the journaling, and really practicing that kind of assertiveness. It's an opportunity for her to explore connections, and we also use the time with her to really encourage her to pursue her own interests, things that she has always wanted to do but hadn't felt comfortable or had the courage to do. She expressed her interest in going to museums and really participating in cultural activities that never felt supported for her or safe for her to pursue in her neighborhood. So really was able to let her have a sort of blossoming of finding herself at the respite.
Great. Thank you, Lauren, for that example. Just wanted to ask Brenda if she would like to say anything else. I know you talked about the intensive component earlier, but if you wanted to just repeat it or mention anything about this, and then and also Doug, if you had any follow-up thoughts. But Brenda, anything to add at the moment?
Yes. So as I said before, the intensive is really if a person has an SUD that is out of control and that they really need a high level of care, there are better suited levels of care available, such as stabilization or inpatient rehabilitation that they can access. We're in the process of doing residential redesign, and there will be really some work that will be coming out to show where those are at. I think that, you know, there are a lot of individuals with co-occurring disorders, and for the intensive crisis respite, that may be some place that they can go, but for those who have SUD disorders that are in need of a high level of care, that can be taken care of in a different level of care through our system. Thank you.
Great. Thank you, Brenda. And again, thank you to all the presenters. What I'll do now is just quickly go through some of the information and again, remind folks that this presentation is posted already on the MCTAC.org website. We're also recording this, and the recording version of this will be available later in the week or at least early next week. But again, for the individuals in the call right now, these are just the links to the manuals, the designation application, especially for the rest of the state, the billing manual, and the fee schedule and rates. So we just wanted to highlight that. As I mentioned before, the upcoming training sessions, some that already clearly occurred, other ones that we are planning to have, as we discussed during the presentation. So the ones that are coming, the next one is on the billing training, and so that email and information went out earlier, and we're developing the plan of care training session as well. So just stay tuned for more information on that. This is just a highlight of the HCBS services, what has been conducted, and and the next one that's coming up, our last service, is the July 31st, this Friday, which will be the last cluster that's referred to psychiatric rehab, that has 3 services there, and so we'll be conducting that this Friday, which will then conclude the HCBS overview presentation. As mentioned earlier, we'll be doing more a deeper dive and more in-depth, probably in-person presentations in the fall, early winter on all of these services. And as we kind of move along, and again, just to remind folks, if you, even after this presentation, have any questions, you're always free to email us at mctac.info@nyu.edu. And the website is mctac.org. And for the individuals who are listening in, if you have any questions, please chat them in. And I think we're now going to turn into the question and answer portion of this. So the first question that we got was in regards to mobile crisis. So mobile crisis is and was listed in the manual. It has been removed probably a couple of months ago or so. And my understanding, and Doug and Brenda, please jump in, it's being moved under the state plan services and will be available to a broader population. And that's why we did not go through it here, because this is only for HCBS services. Doug, Brenda, is that accurate to your knowledge?
Well, I think it's moving to the demonstration. So it's not exactly state plan service. It will be a service that will be available to everybody in Medicaid managed care. You won't necessarily need to be in a HARP, but you will need to be enrolled in Medicaid managed care.
Gotcha. Thank you. Okay. So let's just go through some of the questions that I got. And just to underscore, there's a question for the crisis respite that we just reviewed. The individual does need to be in a HARP. They do not need the assessment, the INTERI or the New York State Community Mental Health assessment to be conducted, but they do need to be in a HARP. And so we just wanted, it's in the presentation, just underscore that for these 2 crisis services. Let me go through. There's a question on can homeless clients use this service? I think there'll be further guidance on that coming along. Again, Doug, Brenda, your comments on that question?
Yeah, I agree with you. We'll have further comments. We just don't want people to look at this as a long-term housing option, and so I see where the question is coming from, but we'll provide more guidance.
Okay, thank you. We have a question here. It says, if a mental health agency is proposing to provide crisis respite, is it the expectation that they will provide the service to those with mental illness and those with substance use disorder? I guess this could be both a co-occurring or duly diagnosed, and or questions. So I'll leave it to Brenda and Doug.
Well, again, this will be something that will get you more detail on, but you're being designated to provide this service to both populations. There isn't a separate designation for a crisis respite service for mental health disorder versus SUD disorder. It's a crisis respite service for people with behavioral health disorders. So we'll get you more detail, but I think that you'd be expected to serve anybody that is eligible.
Okay. Great, thank you. There's also a question about HARP and Health Home Case Manager. Again, my understanding is yes, HARP members should be enrolled in the health home and should have a case manager, but not every HARP individual currently and probably in the near future will have a health home case manager. But in neither of those cases, it does not preclude, as far as I understand, the individual getting the crisis respite services, again, as long as they're HARP members. So if somebody, for some reason, at the moment when they need crisis respite, do not have a health home care manager, they still are able to obtain it. I think that would be a good opportunity, of course, after the individual is more stable, to maybe talk to them about a potential health home enrollment or case management, but they do not need it. Again, I just want to confirm with Doug and Brenda if that's your understanding.
Yeah, I agree.
Yes, that's my understanding.
Okay. The next question, I think it's also probably will fall under the category we will be addressing it. It's somewhat related to the homeless question. It's if a family member refuses to take the client back home, I think it's safe to say that we will be having those type of discussions later in the fall and early winter in regards to how those would be handled. Okay?
Yes.
Okay. Can hospitals refer to the program if they don't feel the individual needs their level of care? I believe that's one of the reasons these services were put together.
Yeah, hospital certainly, as we said, as a step down or as from the emergency room. So hospitals certainly can make referrals.
Right. And so a follow-up of it, can the referral come from, I guess, incarceration from jails or prisons?
You know, I'll have to get back to you on that, but I don't see any reason why not. But there's a whole process that we have in place for, especially for discharges from our facilities in state prisons, and I think for the case of New York City for Rikers Island. So there's probably a better answer than I can that I can provide today. So we'll get more information on that.
Okay, thank you. And the question about intensive respite, it's a voluntary placement, correct?
Yes, all these services are voluntary.
Okay. Okay, there's, again, this probably will also fall into further discussion in the fall. Can both the intensive and short-term crisis respite share space and staff? I think that's something we probably would need to address later.
I agree.
So there are some questions on staffing and who is the mental health or mental health treatment staff. I think in the manual there's a list that describes that. So I would advise folks to reference or refer to the manual. In regards to the authorization, there is no prior authorization needed for intensive respite, at least for the initial day or so, but I suspect similar to short-term, And again, as Doug talked about in his presentation, you know, as days progress, there might be and probably will be requirement for ongoing stay in these crisis services. Okay, some of the questions we have already answered. Are AOT clients eligible? I assume they are, but
I would not see any reason why they would not be, so I would assume they are as well.
How will managed care know which providers are qualified for these services? So the state had designations out there. Those lists were provided to managed care companies. So that's how the managed care companies know, and the rates were also posted with that. Is there any limitations of, I guess, catchment area or staying within your area? I don't think there is a limitation on that, but we can always come back to it.
Yeah, I don't think so either. I think that we envision, especially when you get to areas that are not as densely populated as New York City, that some of these things might even be regional.
Right. Okay. There's a question just to confirm. The 7-day is the maximum for any episode, just clarifying, and 21-day maximum limit is for a year. It's, I believe it's the same for both short-term and intensive as a limit. But again, as Doug mentioned during the presentation, if the individual needs more, those could be discussed with managed care, and more services could be you know, authorized if the managed care and the provider can come to an agreement. Let me just see, just quickly going through some of this here. Okay, I think just quickly going through it. So I think we've gone through most of the questions. And we're a couple of minutes ahead of schedule. So again, I just want to invite folks to email us at mctac.info@nyu.edu if you have additional questions, and we'll be more than happy to answer. We're also going to be posting this and, as I said, recording this on website. And I want to again thank all of our presenters for participating and presenting, and look forward to Friday. So thank you, everybody, and have a wonderful afternoon. Take care.
Take care. Thank you.
Thank you.